Hello, my name is Alejandro Rico and I am going to talk about a randomized trial of high flow oxygen therapy in infants with bronchiolitis. Bronchiolitis is a common illness of the respiratory tract. It is caused by an infection that affects the tiny airways called the bronchioles that lead to the lungs. As these airways become inflamed, they swell and fill with mucus, which can make it breathing difficult. Now we pass to a video.
What is bronchiolitis? Bronchiolitis is the inflammation of the lungs caused by a viral infection in children usually less than 3 years old. Symptoms of bronchiolitis can be severe, especially in infants less than 6 months old. Symptoms include wheezing and labored breathing, frequent coughing, mild fever, runny nose, and decreased activity level. Regarding treatment, sometimes less is more. Since the disease is viral, antibiotics won't cure it. They may be used for complications only. Also, breathing treatments with albuterol rarely help and can cause additional side effects, such as increased heart rate and decreased blood oxygen levels. Most cases of bronchiolitis can be managed at home with good hydration and nasal suctioning. Symptoms will often improve in 3 to 5 days. Bronchiolitis is a diagnosis your child's doctor can make with a thorough exam. In that case, their doctor will write a prescription so they may visit the Via Christi suctioning clinic once or twice a day for a few days. Fewer children still might require an admission to the hospital for closer monitoring, IV fluids for hydration, and even a tiny amount of oxygen until their lung inflammation begins to heal. Bronchiolitis can occur several times during childhood, but thankfully is usually more mild each episode. Learn more about nose suctioning by going to viachristi.org/suction.
Now we pass to application in medicine. For the treatment of bronchiolitis, it is recommended the use of acetaminophen to reduce fever and standard or high flow oxygen therapy. Pros and cons of high-flow oxygen therapy. Pros: less risk of failure of the treatment, highly effective. Other benefits as faster regeneration of scars. Cons: high cost of treatment is not found in all hospitals at Ecuador.
Hi, I'm Kauthar Sayi, Product Manager at Hamilton Medical and responsible for high-flow oxygen therapy in our ventilators. Today, high-flow oxygen therapy is widely used for the treatment of acute respiratory failure in critically ill neonates, pediatrics, and adults. With high-flow oxygen therapy available as standard or optional feature on almost all our ventilators, we offer an effective solution for all patient groups. You can easily switch between invasive or non-invasive and high-flow oxygen therapy without changing the device or even the breathing circuit. Only the ventilator mode and the patient interface have to be changed. You can deliver a fraction of inspired oxygen between 21% and 100% at a flow up to 60 liters per minute with the Hamilton G5 S1 and up to 80 liters per minute with the Hamilton C3, C1 and Hamilton T1. The delivered flow is heated to 37 degrees Celsius and optimally humidified to 44 milligrams of water per liter using the Hamilton H900 humidifier. Continuous display of plethysmogram and SpO2 values using neon Coden or Massimo pulse oximeters allows you to monitor the oxygen administration and to minimize the risk of hypoxemia and hyperoxemia. We also provide all necessary consumables such as both dual limb and single limb breathing sets and nasal cannula. Would you like to know more about high-flow oxygen therapy with Hamilton Medical ventilators? Have a look on our website or YouTube channel or sign up for our e-learning program.
Now, issues apply in Ecuador. In Ecuador, most of the cases of bronchiolitis are treated with the standard flow oxygen therapy. This is due to the lack of equipment for the high-flow oxygen therapy and the cost of the treatment.
Gives me a little more strength in not wanting to do it, because even if the x-ray is abnormal, RSP can give you an abnormal x-ray, and then you see it abnormal, so then you give antibiotics for something that is truly not indicated. So they're kind of saying, well, unless they have focal findings in their lungs, like not just wheezy congestion, but one side more than the other, then you get the x-ray, or if they're getting admitted, then of course. Steroids don't really help, and then the breathing treatments. So maybe steroids, I'll prescribe it less, but breathing treatments, it's a security blanket. It gives the parents something to do. They go out home with something to do for that child. And you've seen many bronchiolitis kids actually improve with the breathing treatment. Even though the revisits for bronchiolitis have really not changed, the admissions of those kids does not really change, and maybe the duration of the symptoms doesn't really change by what you did, it gives the parents something to do. So I'm still going to give the albuterol. Maybe not so much the steroids, or maybe I'll do 1 dose of steroids instead of 5 days of. But I'm not going to change that part because parents need something to do. What it did discuss was something I didn't think about. If they have a really high respiratory rate, the fact that these kids, even if they're not vomiting, even if they don't have diarrhea, they might actually get significantly dehydrated. So to watch for dehydration, to be aggressive about hydration, and about all the things, maybe put an IV and give them a fluid bolus will help with the respiratory rate. And I didn't know that. So that's what I learned from that article. All right, that's it.
Okay.
All right.
Now, conclusions. High-flow oxygen therapy reduces treatment failure. Best way to treat hypoxia caused by bronchiolitis. In Ecuador, this treatment is expensive compared to the standard flow oxygen therapy. To reduce fever, we give acetaminophen to the person with bronchiolitis.
We have 1 critical minute to focus on oxygen therapy. There are many ways to give your patient supplemental oxygen, but how much should you be giving and how much are you actually giving? Common target values of oxygen saturation in the hospital are over 95% for the vast majority, 92 to 96% for acute medical conditions, and 88 to 92% for people with COPD or ARDS. Note that giving too much oxygen leads to oxygen toxicity caused by absorption atelectasis and direct tissue damage, especially lung injury, by the formation of free oxygen radicals. This is associated with a higher mortality in acutely ill patients. Link in the description for a recent article published in The Lancet. The fraction of inspired oxygen of room air is 21%. The most common methods of administering low-flow oxygen on a medical or surgical ward are through a nasal cannula, a simple face mask, or a non-rebreathing mask. The amount of oxygen you administer is titrated with the flow. Take a look at this table to see how much flow corresponds with the FiO2. You then get a better feel for how much oxygen your patient needs compared to room air. In summary, go as low as you can go. You are dismissed.
Thank you.